All right, so my name is Michael. I'm one of the endocrinology fellows, and I'm going to be giving a quick talk about diabetes mellitus. Just an overview or an outline of what I'll be presenting today. We're going to start by talking about diabetes mellitus in general. We'll talk about the classification and diagnosis, and then we'll also talk about type 1 diabetes and cover the important things that you'll be tested on your board exam. And we'll talk about ketotic hypoglycemia, and then we'll finish up with talking about DKA. So to start off, diabetes mellitus refers to a group of metabolic disorders characterized by hyperglycemia due to one of the following: insulin deficiency, failure of insulin to function correctly, or failure of specific target organs to recognize or utilize insulin correctly. As far as the diagnosis of diabetes mellitus in general, it can be diagnosed if one of the following 4 criteria are met. First being a fasting plasma glucose greater than or equal to 126, and fasting is defined as no caloric intake for at least 8 hours. Another criteria is classic symptoms of hyperglycemia and a random plasma glucose of greater or equal to 200. A third criteria is a 2-hour plasma glucose greater than 200 during a standard oral glucose tolerance test. And the fourth criteria would be a hemoglobin A1C greater than or equal to 6.5%. Regarding the classification of diabetes mellitus can be classified into the following categories. The first is type 1 diabetes. Second, type 2 diabetes. Third would be gestational diabetes, which is diabetes diagnosed in the second or third trimester of pregnancy. And fourth, other causes of diabetes, such as monogenic diabetes syndromes, which includes neonatal diabetes, maturity onset diabetes of the youth, or MODY, diabetes due to disease of the exocrine pancreas, specifically with CFRD or CF-related diabetes, or related to chronic pancreatitis, or drug-induced or chemical-induced diabetes. An example is steroid-induced diabetes. We're going to focus primarily on type 1 and type 2 diabetes for your board exam. So as far as type 1 diabetes, the board wants you to understand the natural history of type 1 diabetes. So type 1 diabetes is deficits of endogenous insulin and dependence on exogenous insulin to prevent ketosis. And this is an autoimmune process where there's destruction of your beta cells of your pancreas, which secrete insulin. It's more common in the Caucasian population. Girls are equally affected as boys. And the peak presentation of a new onset type 1 diabetes patient is between 5 to 7 years old, and then another peak presentation is at puberty. But one thing to know is that there is a growing number of new onset type 1 diabetes being diagnosed in early childhood in children as young as 1 to 2 years of age. And the most common presentation as far as seasons is during the autumn and winter. The board also wants you to recognize the clinical features associated with type 1 diabetes. So the clinical features of type 1 diabetes is polyuria, polydipsia, polyphagia, and weight loss. Generally, when patients are diagnosed with type 1 diabetes, family notes that these polys and weight loss have been ongoing for a few weeks. Ketoacidosis is a presenting finding in approximately 25% of children with diabetes. Some additional clues in the question stem that you might see to help you think about a diagnosis of diabetes would be a history of enuresis in a previously potty-trained child, lethargy or weakness, or an adolescent girl who has skin infections or vaginal candidiasis. The board also wants you to plan appropriate diagnostic evaluation of new onset type 1 diabetes. So evaluation for type 1 diabetes should occur when there's classic symptoms of diabetes combined with hyperglycemia. Here at Cincinnati Children's, our usual diagnostic evaluation includes a renal panel, which has a sodium, glucose, phosphorus, calcium, and your magnesium, a urinalysis, to evaluate for glucosuria or ketonuria. A CBC with differential if there is a concern for an associated infection. And then we do our new onset screening labs, which includes an islet cell antibody screen, an IgA and TTG IgA to screen for celiac disease, and if they're not presenting in ketoacidosis, a TSH to screen for hypothyroidism. Regarding treatment of type 1 diabetes, the American Diabetes Association recommends the use of intensive insulin therapy for all patients with type 1 diabetes with the use of analog insulin, and when feasible, monitoring blood glucose levels at least 3 times per day. Regarding intensive insulin therapy, that is in reference to 3 or more injections of insulin per day using either a needle and syringe or an insulin pen, or it could include using an insulin pump. Here's a picture of an insulin pump where the patient will wear a device which will infuse insulin subcutaneously throughout the day, and they're able to bolus insulin for coverage of their carbohydrates or blood sugar correction via their pump and not have to do an extra injection. Regarding blood glucose monitoring, there are 2 current methods of home blood glucose monitoring. The first is via a finger stick and a glucometer. And then the second is with a continuous glucose monitor, or also known as a CGM. The CGM, similar to an insulin pump, is worn by the individual, and generally that CGM site or sensor is changed every 10 days. How the CGM sensor works is that it monitors blood glucose via the interstitial fluid. Regarding types of insulin, there are 4 main types of insulin. The first being rapid or short-acting insulin, and this is your Humalog or Novolog. You have intermediate-acting insulins, and the most common one is NPH. There are also long-acting insulin, and this is your Lantus, Basaglar, or Tresiba. And then there are also mixture insulins. The more common one used is Novolog 7030, which is a combination of a short-acting insulin and an intermediate-acting insulin. This is a graph that shows the onset, peak, and duration of action of various types of insulin. Some insulins to note that are more commonly used are your Aspart and Lispro, which is your Humalog and Novolog. The peak of action, the onset of action is within 5 to 15 minutes. Your peak action is between 30 to 90 minutes, and then your effective duration is about 4 to 6 hours. The other insulin to note that is more commonly used is your Glargine or Lantus, which has an onset of action of about 2 to 4 hours. There is no peak of action, and the duration of action lasts about 20 to 24 hours. Regarding insulin therapy in children with type 1 diabetes, there are 2 main regimens, the first being a regimen of multiple daily injections with analog insulin, so that's your Humalog, Novolog, and your long-acting insulin such as Basaglar or Lantus. And this is your typical basal bolus regimen where a basal insulin is given and then bolus insulin is given throughout the day for carbohydrate coverage and blood sugar correction. The second approach to insulin dosing in children with type 1 diabetes is multiple daily injections with mixed insulin. This is less commonly used, primarily because it's more restrictive in regards to they have strict carbohydrates they need to eat throughout the day, so they have to have regular meals. But it is effective in families who have difficulty with understanding carbohydrate counting, or if analog insulin cost is an issue for them, this is another option that could be used. Regarding self-management of type 1 diabetes, the first aspect of that is glucose monitoring. Generally, it's recommended that glucose is monitored 4 to 6 times per day. And that could be done via finger stick glucoses or a continuous glucose monitor. The other key thing in glucose monitoring is monitoring an A1C, which is an average of blood sugar control over 3 months, and which we use in the outpatient setting. General targets that we like to target are a blood glucose before meals ranging from 90 to 130, a blood glucose at bedtime or overnight between 90 to 150, and an A1C less than or equal to 7.5% in our pediatric population. The other important thing in diabetes self-management is a healthy diet, which includes carbohydrate counting and covering the carbs eaten with bolus insulin. And then another important thing is exercise. Regarding long-term complications, there are three most common long-term complications. The first being retinopathy. Here in this figure, on the left is a normal retina, and on the right is a fundoscopic exam of someone with diabetic retinopathy. Note the cotton wool spots, the microaneurysms, and the neurovascularization. The second most common long-term complication is nephropathy. Here is an electron micrograph of a cross-section of a glomerular capillary. Note on the figure on the right that there's a thick basement membrane. Here is also another microscopic photograph of a normal glomerulus on the left, and then on the right a microscopic photograph of a glomerulus that has been distorted or compressed by some nodular scarring. And then the third most common long-term complication that we screen for in type 1 diabetes is neuropathy. Other complications are celiac disease, hypothyroidism, or cardiovascular disease. Regarding long-term complications, as far as screenings that we commonly do are autoimmune condition screening, cardiovascular risk screening, and microvascular complication screening. It's likely that you may have a question on your board exam about long-term complications. So here is an example prep question. So there you have a 13-year-old adolescent girl with diabetes mellitus who presents to your office with her mother for a health supervision visit. The mother reports that over the past 4 months, the adolescent has had loose stools, intermittent abdominal pain. There's no associated emesis. On physical exam, she appears comfortable. Her heart rate is 71, her respiratory rate's 18, her weight is at the 9th percentile, and her BMI is at the 4th percentile. A year ago, the adolescent's weight was at the 36th percentile, and her abdomen is distended, non-tender, and tympanic with normal bowel sounds. And the question is, of the following, the most sensitive screening test for this diagnosis is? So I want you to go ahead, pause the video, and decide what your answer is. And then when you've got that done, go ahead and restart. So about long-term complications with type 1 diabetes regarding screening. So we talked about how you want to do autoimmune condition screening. So that is done, you screen for thyroid disease, and that is done with a TSH plus or minus thyroid antibodies. And screening is soon after diagnosis and can be done every 1 to 2 years or sooner if symptoms develop. The other autoimmune screening that we do is for celiac disease, and that is done with an IgA tissue transglutaminase antibody with documentation of normal serum IgA. If the patient is IgA deficient, IgG tissue transglutaminase antibodies can be used, or IgG deaminated gliadin peptide antibodies can be used to screen. As far as screening, screening is recommended at diagnosis, at 2 years and 5 years post-diagnosis, and if clinical symptoms indicate. Cardiovascular risk screening is done with blood pressure at each follow-up visit, a smoking history, fasting lipids. Once metabolic control is normalized, we do recommend that fasting lipids are checked. Our goal LDL is less than 100, and if abnormal, we do recommend to recheck fasting lipids annually and if they're normal, you can recheck fasting lipids every 5 years. Regarding microvascular complication screening, these are done annually once a child hits puberty or at 10 years of age, once the child has diabetes for more than 5 years. As far as microvascular complications, we monitor for nephropathy, which is done with a random spot urine for albumin to creatinine ratio, retinopathy, which is done with a comprehensive eye exam, and neuropathy with a comprehensive foot exam. So back to our prep question. So you have an adolescent girl who comes in with symptoms of loose stool and intermittent abdominal pain. She also has a diagnosis of diabetes mellitus. She has some interval weight loss, and then she has a distended abdomen on exam. So the suspicion at this point is that she has a new diagnosis of celiac disease. So your answer, the correct answer would be E, tissue transglutaminase IgA. The board also wants you to know how to manage hypoglycemia in individuals with type 1 diabetes. So general symptoms of hypoglycemia are pallor, tachycardia, sweating, hunger, drowsiness, sometimes seizure or coma, or some mood and personality changes. Some causes of hypoglycemia in our patients with type 1 diabetes are a honeymoon period where their pancreas is still making some insulin. This usually is for a time after diagnosis. There could be errors in insulin dosing. Generally, over-insulinization will cause hypoglycemia. Another cause would be calorie restriction or sustained strenuous exercise. As far as treatment of hypoglycemia, we generally use what's called the rule of 15. And what is involved with that is to treat hypoglycemia, generally a blood sugar less than 70 with 15 grams of carbohydrates, wait 15 minutes, and then repeat a blood sugar 15 minutes following, and repeat that as needed. In an event where patient is unable to take carbohydrates orally, there is an emergency supply of glucagon that they can use. And one thing to note is that can cause emesis after use. The board also wants you to know about ketotic hypoglycemia. So the classic presentation of an individual with ketotic hypoglycemia would be a lean 3 to 5 year old with an acute illness who skips dinner and sleeps through breakfast and then wakes up around 10 a.m. with a hypoglycemic seizure. The pathogenesis of ketotic hypoglycemia is depletion of your liver glycogen stores after a 12 to 18 hour period of not eating. Generally, the labs consistent with ketotic hypoglycemia would be hypoglycemia. Generally, it's in our children without type 1 diabetes, so generally their blood sugar is less than 50, and they have ketones, positive ketones in their urine. As far as the treatment, it's to avoid prolonged fasting, especially in times of illness. And the prognosis is good. Generally, children will outgrow this diagnosis of ketotic hypoglycemia as they gain more muscle mass and increase in weight. And finally, the board wants you to know how to diagnose and manage diabetic ketoacidosis, or DKA. DKA is the leading cause of morbidity and mortality in children with type 1 diabetes, and that mortality and morbidity is primarily due to cerebral edema. 75% of DKA is diagnosed in children with type 1 diabetes who are not taking insulin or who are not taking their regular insulin. As far as a diagnosis of DKA, it includes hyperglycemia, generally a glucose level greater than 300, ketonemia, which leads to ketonuria, acidosis with a pH less than 7.3, and a bicarbonate level less than 15. As far as general principles of treatment of DKA, it includes expansion of your intravascular volume, correction of fluid deficits, correction of electrolyte abnormalities, and finally correction of acid-base status. So the first principle is expand intravascular volume. Generally, this is done with normal saline with a bolus of 10 cc's per kg, and you can repeat that as needed. Regarding correcting fluid deficits, most children at presentation of DKA are about 10% dehydrated. Here at Cincinnati Children's, we start with fluids that are calculated using 300 milliliters per meter squared per day. There is currently no consensus of using normal saline versus half normal saline for replacement or maintenance fluids, but a good general rule of thumb is to use half normal saline if there's no evidence of hypernatremia. Regarding correcting electrolyte abnormalities, fluid should always contain potassium due to intracellular transport of potassium when acidosis corrects. So generally we replace with 40 to 60 milliequivalents of potassium, and there's various ways that you can replace this potassium with potassium chloride, potassium acetate, or potassium phosphate. And then the fourth general principle of treatment of diabetic ketoacidosis, or DKA, is to correct acid-base status, and that is done using an insulin drip with a dose of 0.1 units per kg per hour of regular insulin. Some things to remember is you want to always continue your insulin drip as long as acidosis is still present. But if you're dealing with hypoglycemia on your insulin drip, you want to titrate your dextrose to respond to that. And the last thing to remember about correcting acid-base status is bicarbonate administration is no longer recommended unless in very severe cases of acidosis. As far as complications of treatment and management of diabetic ketoacidosis, or DKA, one complication is cerebral edema. Generally, cerebral edema will present 6 to 12 hours after starting therapy. It generally occurs when a child is appearing to improve both clinically and on lab measures. Some risk factors of cerebral edema are younger age, less than 5, new onset diabetes, a low initial PCO2 or more severe acidosis, a decrease in corrected sodium with therapy, and treatment with bicarbonate. Some initial manifestations of cerebral edema are headache, a change in alertness, vomiting, or some delirious outbursts. Here's a picture of a normal head CT on your left, and on the right a picture of a head CT of someone with cerebral edema. One thing to note is the effacement of your sulci and also your lateral ventricles. Also to know is there could be some evidence of Cushing triad with cerebral edema, which is the triad of increased blood pressure, decreased heart rate, and irregular breathing. As far as treatment of cerebral edema, that is done with mannitol or 3% saline. Another risk factor or complication of treatment of DKA is hypokalemia, and this is due to your total body depletion of potassium. So as a reminder, as acidosis corrects, potassium is brought back into the cells, and you can see U waves on EKG. And the last thing that the board wants you to know is that the most common cause of recurrent DKA generally is noncompliance.